Attention please, ladies and gentlemen. There are few instructions to be given regarding the quiz. So while you're enjoying your refreshments, I urge you to pay your attention. The following segment is a quiz competition where you will be given a responsive device. And once the speaker put up a questions on the screen, there will be a panel which has the answers. Once the panel, as it is put up, the panel will be in red color. Once it turns to green color, you go to select your answer. So the device that will be given to you will have numbers or the letters. Whichever the preferred answer, you can select, and as many times as possible you can select if you want to change your answer, that is, as long as the bar is in green color. And once you press the number or select the answer, there is a small indicator bulb in the device which will turn green. Otherwise, it will keep on blinking yellow color. So once they record your answer, it will turn green. Let me repeat the instructions again. Each one of you all will be given a handheld device with numericals. And when the moderator asks you a question, for you to answer, you have to wait until the bar is green color. When it's green color, you can select your answer. And if you want to change the answer, you can do that as long as the bar is in green color. And when you answer or when you select your answer from your device, there is an indicator bulb which will turn green, which means that your answer had been recorded. Because of this process takes little time, we urge you to quickly finish your refreshments and come back and settle down in the main hall so that we can start this quiz as soon as possible.
Good afternoon, everyone. Can you come into the the presentation hall, because the quiz is going to start now, and you all will be given the small device and I think the instructions was given. So you can actively participate for this program, and you can challenge your knowledge. And I would like to invite Professor Ricardo Fontes Cavello. He's from Portugal, and I don't need any introduction on him because he did a quiz yesterday as well as today morning he delivered a presentation. Without taking much time, I would like to welcome Professor Ricardo. Yeah.
Thank you very much. Good afternoon, everybody. In this session, we will do it in a bit of an informal way. We will try to have a very educational session so that at the end of each case, we will have some take-home messages for our clinical practice. As we said before, it will be an interactive session, so we will have opportunity to vote. Be fast voting, because we will only have 10 seconds to vote and to guess the diagnosis. And the third thing is that all of the presentation, all the cases that I will show will be good because they are real-life cases, and I'm sure that we will all learn a lot in this kind of cases. So, the first thing, I usually say this to my fellows, sometimes when you are a doctor, it's like being Sherlock Holmes, because it's difficult when you have to guess the diagnosis, but one thing that he used to say is, in medicine there is no fiction to medicine, to fiction in medicine, because the facts will always beat anything you fancy, and we will see this throughout the presentations, throughout these cases. So let's start. The first case that we will have is important because it reminds us of an important message from William Osler, who usually said that it is important to listen to your patient because frequently he is telling you the exact diagnosis. So, let's start. The first one is a female with 62 years old. She had no cardiovascular risk factors, and the previous medical history was she only had anxiety. She was admitted to the hospital because she had a chest pain with 3 hours duration after knowing that she was going to become a grandmother. The cardiac auscultation was normal, and the physical examination, it was relatively normal. She was hypertensive and a bit tachycardic. This was the EKG of the patient, okay, at admission, so look carefully to the EKG. I'm not going to comment and to go into much details. So let's look at the EKG, and then this is the echo that was performed when she arrived to the emergency department, because the patient also had a moderate elevation in the troponin at admission, okay? So look carefully to the images. So, first question, you can start voting. Is this an ST elevation myocardial infarction, non-ST elevation, a Diagora syndrome, or a Kunish syndrome in terms of diagnosis? I don't know if you voted. Probably it was too fast. Yeah? So probably, okay. We will try to vote in the next one, okay? I had something, there is some technical detail here. Okay, so let's try to see what further data do we have in terms, you cannot vote, yeah. Let's see what further data do we have. The patient was sent to coronary angiography, and you can see that on the left and on the right coronary angiography, you had no coronary artery disease in this patient. So, if you look carefully to the images that I showed you, the patient actually had an hypokinesia of the basal segments of every wall. You can see it better here in the contrast echocardiography here. And there were important clues in the medical history of the patient to reach the diagnosis. This was a postmenopausal female. She had no cardiovascular risk factors. The pain occurred after an emotional distress, and she had a previous psychiatric disorder. So, what does this mean? She performed also an MRI. You can see that she had no late gadolinium enhancement. She had a complete recovery of the left ventricular function. So the correct diagnosis would be what we call now the happy heart syndrome, also known as the Diagoras syndrome. What is the Diagoras syndrome? This is based on a true story, which is a legend from the ancient Greece, which is the story of Diagoras. I don't know if you know the story, but Diagoras was the most famous athlete of the ancient Greeks. And when he won an important competition, he was called to the middle of the arena, and before more than 20,000 people, he was appreciated like being the greatest athlete of all time. But when he was in this peak of the happiest moment in his life, someone cursed him and he said, "You will die now." And since then, the Diagoras story is the paradigm of the happiest possible death that you can have in the peak of glory. So, actually, this is important because it has some important take-home messages. The first take-home messages is, this is of course as a case of stress cardiomyopathy, also known as Takotsubo syndrome. And actually, we know now that this can also be triggered by joyful or socially desirable events. And there are no major differences regarding the traditional presentation. The second important take-home message from this case is that not all Takotsubo syndromes appear in the classical form. We know now that some people, like in this case of this woman, have a reverse Takotsubo. You could see that she had hypokinesia in the basal segments. And there are also mid-ventricular type of Takotsubo syndrome. So, here you can see an example. This was our patient. You can see here this area not moving. This is a classical type. And you can see here another patient with the mid-ventricular Takotsubo syndrome. So this is to remind that this is a new consensus that was published this week about the Takotsubo syndrome that you can see here. And you can see here that there are a lot of positive and also negative emotional triggers, also physical triggers that can lead and can trigger this kind of syndrome. One of the options you may remember was a Kunis syndrome. What is a Kunis syndrome? This is known, it is quite uncommon, but it is known also as the allergic acute coronary syndrome. There are several variants, but in summary, this is triggered by the release of inflammatory mediators that trigger a vasospasm, usually of the coronary arteries. And actually, this is a case from our department that we had recently, where you can see after the injection of ciprofloxacin, you see this in the EKG, a significant ST elevation in the inferior wall. And as you can see here, when the patient was sent to the cath lab, she had no significant stenosis, and actually this was induced by vasospasm, and this is known as the Kunis syndrome. So the final take-home message from this case was remembering that this patient, if you saw the clinical history, if you speak with the patient, actually she was telling us the diagnosis because of the clinical context of the patient. So let's go to the second case, okay? And the second case is entitled Never Sleep and Concentrate into Details. Because actually this is inspired in a very nice painting, I don't know if you know it, but it's one of my favorites, which is The Night's Watch. And some of us do a lot of night's watch, and actually this case happened when I was doing my night watch one of the days that I was in the hospital. So the story is more or less like this one. This was a male with 61 years old. He had hypertension and diabetes, and he was doing this medication. I was called, it was 3 a.m. in the morning. I was called because there was a patient in the emergency room with chest pressure, pseudoresis, and acute dyspnea. The physical exam, you can see that the patient was not properly well. He was hypotensive, He had an acute pulmonary edema, and as you can see here, the arterial blood gases were not that good, and actually this patient was in cardiogenic shock. So this was the EKG of the patient. Look carefully to the EKG of the patient. I will comment about the EKG of the patient a bit later. And they call me because they want to request to perform a primary PCI to this patient. So let's give some images. I decided to perform an echo because something was strange in this EKG that we will see in a moment. This was the echo. So prepare to vote, because the next question, we only have 10 seconds to vote. You can see here some wall motion abnormalities, and the possibilities are, is this a perimyocarditis? Is this an interventricular septum rupture? Is this acute myocardial infarction? Or is this an aorta disease? Look carefully. Okay, we cannot see the results. I don't know why. Okay, shall we proceed? I can try to, in the next case, to give more time to the president to vote. So, the first thing to remember in this case is to go again to Sherlock Holmes. Sherlock Holmes was usually said to us, never trust in general impressions and concentrate on the details. Why? Because most people, as my colleagues in the emergency department, when they saw this case, they thought, okay, this is a myocardial infarction immediately. And actually, if you look carefully, I will show the detail in a minute. Actually, this was not a myocardial infarction, because if you look carefully to the echo image here, you could see something strange in the aorta. And actually, what is this? This is a flap in the aorta, in the proximal aorta. And actually, this is the dissection of the aorta, which was extending to the descending aorta, but also involving the left main. As you can see here, these are some images also of the parasternal short axis view, also of the suprasternal view. You can see here the flap moving, okay, here. That is why sometimes the echo is important in the acute phase. It helps in some cases when things don't match exactly. And as you can see here, he also had a moderate aortic regurgitation, which was caused by the dissection. Actually, instead of sending the patient to the primary PCI, with this echo, we took the good decision was to perform the computed tomography. And as you can see here in the CT, you can see a large dissection, and you can see that it was involving the left main trunk. And actually, if you look carefully to the EKG that the patient has, this is highly suggestive of involving the left main. You can see the depression in several leads. You can see ST elevation in the AVR derivation, and this is highly suggestive of an involvement of the left main, which was not caused by coronary artery disease, but it was caused by the dissection of the proximal aorta. So, what are the take-home messages from this case? The first one is to remember the guidelines. The guidelines say this is a C recommendation, but as long as it does not delay the transfer for angiography, if possible, you can perform an echocardiography. 1 minute. Okay, so I will conclude the take-home messages from this, and then we will try to, so that everybody can vote. So this is the first take-home message from this case, and then we will do a small pause so that they can fix the pulling. There is a problem with the pulling option, and they will fix this in 5 minutes. Okay, you can switch. Do you want to comment anything about the first cases? There were some interesting clinical messages from these cases.
Yeah, that's a very interesting case, but we do see those type of cases, but most commonly is, as you stressed, first type of stress cardiomyopathy we commonly see, and there are several cases. But it's nice to know the other types as well.
Yeah, yeah. I agree with you. Also, I would recommend you to read this recently published, it was published this week, which is an international, it's not formally a guideline, but it is a consensus between not only Europeans, Americans, also for people from Australia, on what are not only the diagnosis criteria about Takotsubo syndrome, but also the triggers and how you should treat this kind of patients. The good news is that usually the ventricular function improves after the acute phase, but the problem, you have a lot of patients also with this syndrome, is that in the acute phase, sometimes they have cardiogenic shock. You have to put them with, we had a very recent clinical case, we had to use ECMO for the patient until he recovered again the left ventricular function. So this is usually a difficult case. From the second, this is the typical situation, which is the aortic dissection. That is a diagnosis that we frequently miss in our clinical practice.
Yeah, in the second case, now it is happening, let's say in a poor resource situation. Sometimes we might go for thrombolytics, thrombolysis with AVRST elevation, thinking of left main occlusion. And so if you given in this case without doing echo, it would be a nightmare. End up with nightmare because there is a dissection.
But the difficulty in these cases is that not every time is possible to perform the echo in the emergency department. Even in my institution, is not that I usually wear a pocket echo, which is easy to perform even in the emergency department. But there are several units and several hospitals which don't have a cardiologist. And without a cardiologist on site, it's difficult to perform the echo to reach the final diagnosis. But the issue is, sometimes you feel that something is wrong with the patient. And traditionally, I don't do echo to all my patients with ST elevation. But because this patient had, not only because of the symptoms, but also because of that EKG, which was highly suggestive of the left main, that was why we decided to perform the echo in the emergency department.
So what is your message? That means if you see a left main suspicious in EKG, do you need to do echo in every situation?
It depends on the case. As long as you do not delay the transfer of the patient, I think it is fair nowadays to perform an echo. You know,
I mean, quick, fast echo.
A fast echo, yeah, exactly. The fast echo, just to assess ventricular function and look fast to the patient. And actually, with these new pocket echoes that we have, and there are now a lot of them, and some of them are quite cheap. You know that there is one nowadays which costs about $2,000, which is amazing how it is possible now to have a pocket echo of $2,000. Sometimes it can help in your clinical decision when you are in the emergency department. I'm not sure if we already have everything is okay? Okay? So when everything is okay, you can put again the slides so that we can proceed with the other three cases that we have today. Okay, so we can proceed. So third case. Third case is called Not All That Glitters is Gold. And this is also an important message. Let me move. Okay. And this is inspired in another beautiful painting that I like particularly, which is made with gold leaves, okay, which is from Gustav Klimt. So this is a male that we had in our department with 63 years old, with resistant hypertension, dyslipidemia, and diabetes. Actually, he was a previous bicycle runner when he was young. And he was evaluated in the cardiology outpatient unit because of dyspnea and because he was also hypertensive. But what is interesting is that they called me, because I do a lot of echo, and they called me because the patient had this echo in the apical fourth chamber. You see this significant LV hypertrophy, and going to the details into the 3D echo that you see here. And also, I don't know if all of you are familiar, but nowadays this is very important in the assessment of these patients. The use of the strain imaging is really important in these patients. Here is the image from the strain. I'm not going to comment now, but I will show afterwards. So, what is the diagnosis? Hypertensive disease, cardiomyopathy, hypertrophic, athlete's heart, Yamaguchi syndrome, or a restrictive cardiomyopathy. Okay, so we have a split. No one voted on E, and several people voted on several options. We will try to see what is the answer. So, look carefully because this is very important for the clinical practice. What we have here is a patient with a concentric left ventricular thickening, where you have also this kind of glittering pattern in the echo. You also have other important clues in the diagnosis. You see also there is right ventricular hypertrophy, and you can see also infiltration of the atrial septum. This is highly suggestive, only performing the echo, this is highly suggestive of what we know it is a cardiac amyloidosis. And actually, in this type of patients with hypertrophy, if you see this, which is the apical preservation or apical sparing in the longitudinal strain, this is never a hypertrophic cardiomyopathy. We know now this is something that was found in the last 2 years. This kind of pattern in the strain is highly suggestive of a restrictive, of an infiltrative disease, usually cardiac amyloidosis. So, actually, the patient, you can use this diagram to study this kind of patients with suspicion of cardiac amyloidosis. After studying the patient, after the bone marrow biopsy, the patient had a multiple myeloma, and actually it was the cause of this amyloidosis, and the patient actually died because this has a very high mortality. So this is important to remember, that the good physician is important to diagnose and to treat the disease, but we cannot always treat all the patients, but the great physician is the one that treats the disease, but also gives comfort to the patient and treats the patient, which was the case in this patient. Okay, so in the next question, we only have more two, is important because the title is to do the diagnosis before the cardiac autopsy. And it is inspired in a very famous painting. Not all people know, but it is very famous for the cardiologists because it's a nice painting made in Spain, which is a cardiac autopsy of a patient. And the title is very nice because the anatomy of the heart, and she had a heart. So let's try, prepare to vote. You will have to be fast. I will show 5 images, and you will have to answer which one of the images shows a cardiac tumor, okay? So, I will show the images, and you can vote 1, 2, 3, 4, or 5. Which one has a cardiac tumor? Okay, look carefully. There are several. I will explain the images afterwards, but look carefully because all of the cases are really interesting. Okay, now we managed to have a lot of votings now. So most people think the cardiac tumor is the D option, okay? They are wrong. I will show why. So the first case, this is very typical. People who perform echo should be aware of this, which is frequently we do this kind of image and we see here, it seems to be some tumor or something. Actually, this is not cardiac. This is outside the pericardium, as you can see quite well here. And this is an hiatal hernia, which is coming and compressing the left atrium. This is more common than we think. It is relatively common. If you look to a lot of echoes, this happens frequently. The second image that I showed here, again, this is outside the pericardium, and actually this is not an hiatal hernia, this is what? This is the descending aorta, which is compressing the left atrium. So this was not a cardiac tumor, this was a dilatation of the descending aorta. So this is to remember one thing that is important and which is also in the guidelines, to remember in patients with more than 65 years old, to remember to do the screening of the abdominal aneurysm of the aorta, which is simple to do, and it can save several lives. The fourth image that I showed is also very typical. Once you have seen one of these, you will never forget, and I think this is important because this is common in elderly people. This is the typical case of the caseous calcification of the mitral annulus, as you can see here. This is a benign disease. You should only operate if it is compromising the functioning of the mitral valve, which was not the case in this situation. This patient was asymptomatic, so we don't need to do anything to this patient. The fourth option, which most people voted, was not cardiac. As if you look to the details, as I was showing the image here on the side, you see the 3D echo and you see the subcostal view. It is coming through the inferior vena cava, and actually this is coming from, it is a renal cell carcinoma, which is coming through the inferior vena cava and is coming to the right atrium. So this was not a cardiac tumor also. So the final option would be, and the correct answer will be this one, okay? Remember this one? If you look carefully what this patient had, she had a previous pulmonary embolism. The embolism was probably caused because she had a tricuspid valve fibroelastoma that you could see also in the MRI here, and this was actually the cardiac tumor that we had in this series of images. So, what are the take-home messages from this case? Remember, as Sherlock Holmes said, when you have eliminated the impossible, whatever remains, however improbable, must be the truth, as was the case that we saw here. So, fifth case. This is entitled, "Is this a spider web in your heart?" Probably you have a lot of these cases here, but it's quite rare in the Occident. And this is inspired by a painter. This is a very famous painting from Italy, which is one of my favorite, who actually died of the same disease that this patient will have, okay? So this painter has this interesting story of dying of the same disease. So this was a male with 28 years old. She came with fever, cough, dyspnea, and this was the physical examination with fever, reduced heart sounds, and reduced pulmonary sounds in the left hemithorax. So this is the image, okay? I will ask you to vote what will be the most probable diagnosis in the next slide, okay? So look carefully. You have more images here, okay? This is the apical four-chamber view. This is the peristernal view. And now we will vote in the next slide. So, what is happening? Spongy myocardium, a tumor with pericardial metastasis, an aspergillosis, a tuberculosis, or pericardial cysts. What would you say? Okay, most people are correct. In Europe, almost all people miss this diagnosis because it is quite uncommon. This is very typical, as you can see here, of a tuberculous pericarditis in a patient which had an HIV infection. So what can we see here in the MRI here? You see this very large pericardial effusion. If you look carefully, it had a septal bound, so he had a constriction, a constrictive pericarditis, and what are the take-home messages? This is, we know from the clinical studies, that this pattern with fibrin strands is highly specific of tuberculous pericarditis. With this image, it is almost certain that we have a patient with a tuberculosis. There is some risk of evolution to constrictive pericarditis, as we had in this patient. Also, this is a different one, just to show a different case, which could be similar, but it is another patient. This is a female with 50 years old. At the beginning, we thought it could be tuberculosis also, but if you look carefully, it is a bit different, the pattern. See here, this is although it does not seem it, this is an apical three chambers view. see the MRI of this patient in a minute. It's taking a bit to change to the MRI. It's stuck. I don't know where it is stuck. If you can move forward the slides. This is always the problem with images, a lot of images. Sometimes this happens. Can you restart the PowerPoint, please? This is common here in Sri Lanka, the tuberculous pericarditis.
Yes, it's very common.
Yeah.
And we see a lot of cases as you show here.
Exactly
there are a lot
the
of
same.
septal formation in the pericardial space, and give a similar picture. What the picture showed by you is very, it's a very huge.
What is interesting is this. This is relevant because even this week, the New England had exactly the same patient with this kind of images, so it is a good opportunity also to publish this kind of cases. See, this is different. You see this pattern here, which is quite different from the previous one. So actually, this was a different disease. These were cysts in the pericardial space, and this patient had an infectious disease, which was an echinococcus infection, which is quite rare to have this kind of involvement. So the final case and the final option is this one. This case is entitled Back Among the Living, okay? And actually this is true because usually, as also Sherlock Holmes usually said, education never ends, and it is a series of lessons with the greatest for the last. Let's see. This was a female with 22 years old only. She had no cardiovascular risk factors, and she was at home when the emergency was called because this patient was in cardiac arrest. So this was the EKG when they arrived there. As you can see here, she was in ventricular fibrillation here. And actually, after being cardioverted, this was the EKG at hospital admission. You can see here some key waves, and look carefully to the EKG. But the challenge will not be here. The challenge will be in the echo images, okay? So look carefully to the images, especially the ones with the color Doppler, okay, below. Look carefully, because the color Doppler will have some clues about what is the diagnosis. You can see that the patient in the first images has wall motion abnormalities, especially in the anterior wall. And actually, what will be the diagnosis, we will vote in the next slide. With this pattern that we have here, what is this? A stress cardiomyopathy. Is this, the clock is not counting, I don't know why. A mechanical complication after AMI, an atrial septal defect, a ventricular septal defect, or an anomalous coronary artery. What do people think? I don't know if it is possible to put the clock running. Yeah? No? The clock, okay. We could not get the answers, okay. Let's see what do you see in this image, because it is also important. There is nothing more stimulating than a case when everything goes against you. That is true. Actually, if you look carefully, this was not a mechanical complication. Actually, if you look carefully to this image, this will be an anomalous coronary artery. Why? Because you can see with the rest of the images, this kind of tree pattern with still collaterals, as you can see here. This is the short axis, and you can see that there was a dilated, very dilated coronary artery, only with the echo. So you don't need sometimes to send the patient to the cath lab to see all this. But actually, she went to the cath lab. You could see that she had no left coronary artery. She had a very enlarged right coronary artery, which was sending a lot of collaterals to irrigate the left ventricle. So what is this? The final answer came from the CT. This is important in these cases to perform the CT. And actually, what is this? This is an anomalous origin of the left coronary artery. As you can see, instead of coming from the aorta, was coming from the pulmonary artery. So what are the take-home messages? The patient was treated. As you can see, we put a prosthetic graft from the aorta to the left coronary artery. And as you can see here, the take-home messages from this case are, when you see this, you could see that there was some flow within the myocardium, and the flow was predominantly in diastole, and this was actually the clue to reach the final diagnosis. As you can see here, this is not a continuous flow, this is a flow mainly in diastole. So what is the take-home messages? This is to know, we discussed this yesterday, remember? We were discussing that this is a common cause of sudden death in young people. This is a rare congenital abnormality because most people die when they are very young, but sometimes you have these patterns, and this is called the Al-Kappa syndrome. So the final message from all these cases is this one, and I think this is the most important message that I would like to convey this afternoon, which is the one who studies medicine without books sails in an uncharted sea. But the one who studies medicine without seeing patients, without seeing clinical cases, does not go to the sea at all. So thank you very much for your attention and for the invitation.
Thank you, Professor Ricardo. It was very exciting and enthralling. And actually the quotations and interesting cases with good take-home message. I'm sure our audience has enjoyed it. And thank you once again on behalf of Sri Lanka Heart Association.
Thank you very much.
Thank you, sir. Thank you, chairpersons. After that interesting and interactive quiz, we are moving on to the next segment, which is a plenary lecture on pulmonary hypertension, an update on management by Dr. Nicholas Collins. And I invite Dr. Ajanta Rajapaksha and Dr. Shehan Pereira to chair the session.
Good evening and welcome to the plenary on pulmonary hypertension. And the speaker is Dr. Nicholas Collins, who doesn't need any introductions. Over to you, sir. Thank you.
Okay. Thank you very much. I'd just like to begin by once again reiterating my thanks to the organising committee for asking me to come along. I can't seem to, there we go. It's been quite wonderful over the last couple of days to catch up with friends new and old while I've been here. So again, my thanks. So most of what I'm going to talk about over the next 20 to 25 minutes relates to pulmonary arterial hypertension, or idiopathic or primary pulmonary hypertension in particular. And this has really grown from a disease that had very limited treatment options with a very poor prognosis to a really complex disease with quite complex treatment algorithms. And this in part reflects the fact that we have a much larger pool of randomised data on which to draw both our understanding of this disease as well as its therapy. But one important caveat that will be a recurring theme during the course of the presentation is the availability and the expense of some of these therapies. The medications for pulmonary arterial hypertension are quite expensive compared to a lot of other medications we have available. And the lack of availability in Australia is not unique to Australia, and I know that this is a problem in Sri Lanka as well as other parts of the developed world. And I think what it does highlight is the important difference between international guidelines and recommendations and what is actually practical in the day-to-day setting when working with these patients. In terms of what I'd like to talk about, I'd like to talk about some of the outcomes of the World Pulmonary Hypertension Symposium held in Nice earlier this year. In particular, talking about newer diagnostic criteria and the importance of risk prediction. I'll talk a little bit about the role of the newer agents in pulmonary arterial hypertension and how we've moved from single therapy to dual therapy and potentially in the future to an era of triple therapy. And when I was listening to Alistair Hall talk yesterday about the European guidelines for hypertension, it's clear that this is mirrored in the pulmonary hypertension guidelines as well, this concept of early therapy and the use of multiple agents. I'll talk a little bit about drug-induced pulmonary hypertension and then finish off by talking a little bit about chronic thromboembolic pulmonary hypertension as well, given that we now have medical, interventional and surgical options for treatment of this disease. Now, in the past, we've defined pulmonary arterial hypertension as a mean pulmonary artery pressure of more than 25 millimetres of mercury. And this has really been the basis of therapy and diagnosis now for more than 2 decades. However, we know that in healthy individuals, the mean pulmonary artery pressure is, give or take, 14 millimetres of mercury. And therefore, a mean pulmonary artery pressure of 20 millimetres or more actually represents an abnormal increase in pressure, even if it doesn't meet that pre-existing diagnostic cutoff. And we know that this increase in pulmonary artery pressure can be due to a number of different conditions with different management strategies and different outcomes. And we know that you can increase your mean pulmonary pressure by increasing your cardiac output, by having an elevation in your pulmonary artery wedge pressure, by having a left to right shunt, by having blood hyperviscosity syndromes, but also pulmonary arterial hypertension. We also know that in all of these conditions, that a mean pulmonary pressure of 20 millimetres of mercury is associated with a worse prognosis. And so the inference is that perhaps a mild increase in pulmonary artery pressure is a marker of disease severity. Now, having said that, in a lot of these conditions, there's no evidence that reducing pulmonary artery pressure improves outcome, but I suspect that that's something that will come in the future. And so the outcome of the World Symposium earlier this year is perhaps we should define pulmonary arterial hypertension now as a mean pulmonary artery pressure of more than 20 millimetres of mercury, with a normal pulmonary capillary wedge pressure, with an elevated pulmonary vascular resistance. I include that issue of the elevated pulmonary vascular resistance because it's important when we do take these patients to the cath lab, that is outlined in some of the talks earlier today from Professor Boyle, the need to accurately and completely assess the hemodynamics. And that includes a cardiac output assessment in order to evaluate the pulmonary vascular resistance. Measuring pressure isn't enough. So in terms of the implications of these new definitions, on the plus side, this potentially means early diagnosis and early treatment. And we know from work with bosentan going back a decade now that early treatment for pulmonary artery hypertension makes a difference in outcome. The negatives of this is the cost of these therapies. These medications are expensive. If we're increasing the number of patients we're treating, then clearly we're increasing the cost. The other issue is that our threshold for invasive investigation will likely need to be lower. And I'll be interested in the thoughts of some of the people who perhaps work more in echocardiography than I do. But I find that measurement of pulmonary hypertension at the lower limits of normal, at the upper limits of normal can be quite challenging in what's normal and what's abnormal. You know, measuring the right atrial pressure by the inferior vena cava can be fraught with danger. And so I think patients with mild pulmonary hypertension by echo are going to end up to need to have right heart catheterisation to be more completely assessed. Just to comment now about treatment, there are 3 main treatment pathways. For some time now, we've had agents such as bosentan and ambrisentan, which target endothelin, which is a very potent pulmonary vasoconstrictor. We've had the PDE5 inhibitors, so agents such as sildenafil and tadalafil, which act by increasing nitric oxide, which, as we heard yesterday, is important in peripheral vasodilatation, as well as pulmonary vasodilatation. And we've known for some time that prostacyclin-related agents are important in pulmonary artery dilatation as well. We have newer agents now. We have more potent endothelin receptor antagonists, such as macitentan. We have stimulators of guanylyl cyclase to increase nitric oxide, and that's an agent called riociguat that I'll discuss. And we also have prostacyclin receptor agonists as well, and that's an agent called selexipag. All of these agents have been assessed in rigorous randomised studies with clinical endpoints. It actually differs from bosentan. If you look at the original bosentan studies, that was really looking at changes in 6-minute walk distance and pulmonary hemodynamics rather than clinical outcomes. We know that macitentan is a very potent endothelin receptor antagonist, and certainly in our local experience in Newcastle, we've noted that this tends to have more side effects than some of the pre-existing ERAs. In particular, systemic hypotension and peripheral edema. Riociguat, as I mentioned, acts on nitric oxide, and that's particularly important when we talk about chronic thromboembolic pulmonary hypertension. And selexipag is a prostacyclin agonist, which was added to background therapy in its clinical studies, and so therefore has really introduced the realm, or the concept rather, of triple therapy in pulmonary hypertension. I think the difficulties with these new agents is, are they actually feasible to use? And in part that relates to cost, as I've mentioned before. We know that dual therapy is better than single therapy. The Ambition study, which looked at ambrisentan and tadalafil as initial therapy, showed an improvement in outcome compared to tadalafil or ambrisentan alone. But again, whilst that is the ideal, the reality is not always available. And so the ability to put these patients on two expensive agents is not always practical. Just to comment on therapy in Australia and how we approach our treatment of our patients, is it is dictated by cost and funding arrangements. So the government will fund monotherapy. So we're able to provide all of our patients with a single medication. Typically that's with an endothelin receptor antagonist or an ERA because they are the most expensive. The pharmaceutical industry actually will fund second-line treatment. And so in Australia, it's typically a PD5 agent. So an agent such as sildenafil is tadalafil, and that is because they are cheaper than the ERAs. And certainly in the United Kingdom, where they fund monotherapy initially, sildenafil is the first agent chosen, or at least it was when I last visited there about 18 months ago, and that in part reflects cost as much as anything else. One of the difficulties is, though, I think in the future we're going to be faced with the possibility of triple therapy. And so I include this slide, and I apologise because it's quite busy, but this is a study that came out of Europe that looked at the role of intravenous prostacyclin, both Sentan and sildenafil, as initial therapy in pulmonary hypertension. And as you can see, as you look across at mean pulmonary artery pressure, cardiac index, or pulmonary vascular resistance, there's quite marked early improvements. And so whether this translates to long-term benefit, I think remains to be seen. But nonetheless, the principle that perhaps we are looking at 2 and 3 agents for initial therapy is something I think is going to be reflected in guidelines in the future. Just to turn our attention a little bit now to looking at risk prediction in pulmonary hypertension. And we know this is important because it has the ability to individualise our treatment strategies, and I think that's important when we're looking at expensive therapies, when we have limited resources. It does allow early identification of those who have severe disease to allow transfer or assessment at specialised centres that may deal with things like heart and lung transplant. The other thing that's of value, I think, is informing patients of their prognosis. I think that it's not well understood amongst the lay community what a malignant condition pulmonary hypertension can be. It allows us to learn about the various phenotypes of pulmonary hypertension, whether there's a difference between familial and drug-induced, for example. It allows us to be more consistent in our approach so that depending on a risk profile, we can, if you like, have a uniform approach to our treatment. And as I said earlier, I think it's really important in terms of time of heart and lung transplant, if that is a therapeutic option, and I acknowledge that that's not always the case. There are a number of risk scores that are available. I must say I like the REVEAL registry that came out of the United States. It combines a combination of history and physical examination findings, as well as objective markers of disease, such as 6-minute walk test, NT-proBNP, echocardiography, in particular the presence or absence of a pericardial effusion, as well as invasive hemodynamic markers. And like all things, there's an app, and this is what the app looks like. And this can give you a risk score, giving you some sense of how patients can do, particularly over the first 12 months. I just include a couple of slides looking at that. The graph on the left shows that if you can improve someone's risk profile by improving their hemodynamics, improving their NT-proBNP score, they will do better over the course of the first 12 months. Where those patients whose risk increases, or if you like, accumulates higher risk features, that patient is going to do worse. And similarly, the graph on the right shows that the patients that have a higher risk score at baseline clearly do very badly over the first 12 months, with almost 50% mortality when you have that whole host of cardiac risk, of pulmonary hypertension risk factors. And so clearly there are positives and negatives to this, as there are with many things. Risk factors inform clinicians, they potentially guide future planning. And one thing that I do like about some of these risk scores is that they are independent of the patient's symptoms. Because we know that certainly in pulmonary hypertension, patients can have advanced disease before they will become overtly symptomatic. And by the time the patients become symptomatic with features of right heart failure, you often have irreversible pulmonary vasculopathy, and these patients are uniformly going to do badly. Having said that, it's all very well to identify patients who are going to do poorly, but if you don't have a range of treatment modalities available, then it's certainly still problematic. And as I said, in Australia, we're often unable to escalate beyond dual therapy in terms of oral treatments. And whilst it can influence the decision to proceed to intravenous prostacyclin therapy, my experience is that patients really don't enjoy or appreciate this because it is certainly quite limiting in terms of their lifestyle. And as I said, transplant is not uniformly available. Just touching on drug-induced pulmonary hypertension, it's impossible to be exhaustive in terms of the medications that cause pulmonary hypertension. Although there was a nice paper in Clinical Toxicology by McGee et al. That covered this in some detail. We know that it's very well established that pulmonary hypertension can complicate anorexogens or appetite suppressant therapies. Certainly where I live in Australia, amphetamine use is very high and they are chemically related to these appetite suppressant agents, and so a history of amphetamine use is clearly important in patients who present with pulmonary hypertension. But one thing that struck me yesterday listening to Dr. Cooper talk about myocarditis is the fact that we need to be vigilant with newer drug classes that perhaps they do cause adverse cardiovascular sequelae. And so there are a couple of drug classes that I'll mention in the next slide, which I'm certainly not particularly familiar with, but nonetheless can cause significant pulmonary hypertension. So the treatment of chronic myeloid leukemia has been changed by the development of specific tyrosine kinase inhibitors, and we know that both dasatinib and nilotinib are associated with pulmonary hypertension. Monoclonal antibodies are increasingly used in both malignancy and autoimmune disease, and certainly the two that I've mentioned there, one for breast cancer and one used in the treatment of autoimmune or haematological diseases, have also been associated with the development of pulmonary hypertension. And as I said, it's impossible to be exhaustive in a relatively short talk, but I guess what I would like to emphasise is the need for a thorough drug history in the complete evaluation of any patient with suspected pulmonary hypertension. In the last few minutes, I'd just like to talk about chronic thromboembolic pulmonary hypertension, because this is something that now has gained interest because we have both medical and interventional therapies for this, which we didn't have a decade ago. We know that after patients present with their index pulmonary embolism that they're treated with anticoagulation. We know that a certain percentage of these patients, when reassessed after 2 to 3 months, will have a persistent elevation in their pulmonary vascular resistance. It's also worth noting that chronic thromboembolic pulmonary hypertension can occur without an index pulmonary embolic event, and so it needs to be considered in the broader differential of undifferentiated pulmonary hypertension. A negative VQ scan almost certainly excludes the possibility of CTEPH as a diagnosis, but nonetheless important to think about when you have someone with unexplained pulmonary hypertension. This was previously a very progressive disease with very limited treatment options, but as I said, we now have a whole host of treatment options. Just to talk about the medical therapy options, going back about a decade now, bosentan was studied in patients with chronic thromboembolic pulmonary hypertension, and whilst it improved hemodynamics and biomarkers, there was no significant change in exercise capacity. And as such, bosentan never really gained traction as a therapy for chronic thromboembolic pulmonary hypertension. This all changed about 5 to 6 years ago when riociguat was trialled in these patients, and it not only demonstrated improvement in pulmonary vascular resistance, but also improvement in his exercise capacity. It certainly seems that this agent seems to work a lot better in pulmonary embolic hypertension disease rather than pulmonary arterial hypertension. So riociguat in Australia is almost exclusively used in chronic thromboembolic pulmonary hypertension. Coming down the line, I mentioned macitentan earlier, a very potent endothelin receptor antagonist. This was also used in an inoperable cohort of patients with chronic thromboembolic pulmonary hypertension, again demonstrating both improvements in hemodynamics as well as overall exercise capacity. Now, beyond medical therapy, we have established surgical options such as pulmonary endarterectomy, and I'll touch on that subsequently. We also have emerging interventional techniques such as balloon pulmonary valvuloplasty. We know that pulmonary endarterectomy is an established treatment requiring surgical removal of residual obstructive thrombotic burden, and this can have quite a profound symptomatic improvement in our patients. The procedural mortality is not insignificant, and this is a multi-centre review in 2011. They reported a mortality of about 5%. And certainly in my own experience, there are issues related to wound infection recovery as well. So the last patient I referred for pulmonary endarterectomy came back with a wound dehiscence and a deep sternal wound infection. So beyond mortality, there's certainly significant morbidity associated with surgery. We know that post-operative hemodynamics predict outcome and that there will be a proportion of patients who have significant pulmonary hypertension despite successful surgery. And that reflects the important role of ongoing medical therapy. And as I said, agents such as riociguat and MASI-1010 are going to be the cornerstone going forward. Unfortunately, these patients still experience a late mortality after apparently successful procedures as well, in part related to complications of anticoagulation, but also due to progressive right heart failure due to that persistent elevation in pulmonary vascular resistance that I mentioned. The reality is that this has limited applicability. Firstly, the patients have to be suitable in the sense that ideally the patients have a proximal thrombus burden. Peripheral and distal embolic disease is not so suitable to surgical intervention. And it's quite important to have adequate radiology support who can interpret CT point angiography adequately. And similarly, there's only very few capable surgeons. In Australia, we only have 2 centres that do a large volume of pulmonary endarterectomy, and so therefore we're dealing with a relatively small number of patients with an even smaller number of surgeons. And so clearly a multidisciplinary team approach is going to be important. Just finally, that there is a role for pulmonary angioplasty, and again this is something that has very limited experience. The techniques are very similar to those used in percutaneous coronary intervention, so use of standard guide wires and balloons, and it's used for distal or inoperable disease. The improvement in hemodynamics is not as impressive as it is with surgery, and frequently requires multiple procedures as opposed to a single surgical procedure. But nonetheless, balloon pulmonary angioplasty is something that's coming down the line and is being used in centres around the world. So I guess to conclude, we know that pulmonary arterial hypertension prognosis has improved with advances in therapy. We now have randomised data with clinical endpoints as opposed to endpoints involving simply 6-minute walk testing. We now have changes in diagnostic threshold, and the aim of that is to start our treatment of these patients earlier. We're going to be encouraged to think about early dual and triple therapy, but again, I think this has issues in terms of practicality and cost. And I think finally, just a reminder to consider drug-induced causes of pulmonary hypertension, as well as chronic thromboembolic pulmonary hypertension in those patients with undifferentiated pulmonary hypertension, as they do have alternate and specific treatment strategies. And so again, thank you very much for your attention and for the invitation. It's been a wonderful couple of days, so thank you.
On behalf of the Sri Lanka Heart Association, thank you, Dr. Nicholas, for that wonderful update on management of pulmonary hypertension. Thank you.
Thank you, sir. And next will be a lecture on imaging guidance, how IVUS helps in PCI strategy by Dr. Prasant Kumar. Co-chairs will be Dr. Jagat Herath and Dr. MBF Rahuman.
Yeah, the next topic is on cardiac imaging, and the lecture will be done by Dr. Prasad Kumar. It will be on how IVUS helps me with PCI strategies. Over to you, Dr. Kumar.
Thank you, sirs, and I thank the Sri Lankan Heart Association for giving me an invitation to talk to you all on this subject. In fact, this thing that is, the first question that anyone will ask you is, doctor, why you need to do an IVUS? Isn't an angiogram enough? You'll definitely start thinking, because if your only tool is a hammer, everything starts looking like a nail. So if you have an angio only as your only tool, so wherever you try to see a block, you try to open it. So I'll try to focus on how IVUS helps me in PCI strategy. And in fact, I come from the eastern part of India, where we do almost all our cases are IVUS guided, and we depend on that a lot. Now, you will see that in a normal angio, there will be a masking of complicated lesions on angio. So it is very important that to know ahead, to know all the 3 layers, how it looks like, the exact anatomy. You can exactly see the external media, the innermost layer. All this can be visualized on an IVUS, and there starts the importance of having an IVUS in clinical practice. Now, to interpret an IVUS, in fact, we follow 3 simple steps. First, how to interpret the basic images, how to interpret the complex images, and how to interpret stenting and post-stenting evaluation. Let us come to the interpretation of the basic images. The basic images are just 6 in number. One is the normal, concentric images, eccentric images, soft plaque, fibrotic plaque, calcium plaque. Around all these 6 images, the full IVUS pictures do rotate. So you have to be very sure about what you are dealing with. So first, when you identify the images, try to identify in which category this falls. Next, if it is soft plaque, it is not very bright as the adventitia, which is hypoechoic. Soft refers to low echogenicity, generally due to the high lipid content. It is mostly a cellular lesion. Next, if you think of a fibrotic plaque, you see there is a little bit hyperechoic. And majority of atherosclerotic lesions are fibrotic that we see in our clinical practice. Very dense fibrous plaques may cause so much acoustic shadowing that they may be misclassified as calcified. So you have to be a little bit careful. Now coming to the calcified plaque, that becomes very brighter more. I'm going from the less brighter to the more brighter. The brighter it goes, it is brighter than the adventitia because it obstructs the penetration of ultrasound. Only the lead edge is detected and thickness cannot be determined and results in denervation, so you can get the oscillations of the ultrasound there. Now, for example, you have to, once you get a calcium, you start quantifying it. That is, you quantify it by the arc it encompasses. For example, is it 80 degrees, it is superficial, it is deep, it is both superficial deep. So you classify it depending on the depth and depending on how much degree it quantifies. For example, here you see a 180 degrees calcified plaque, the first figure, and the next one is a 270 degrees, because this will help you in strategizing whether you would like to do just a cutting balloon or you would like to do a rotablation. Next, these are mixed plaque, where you see areas of soft plaque, fibrous plaque, calcified plaque. They're mixed pictures, which you commonly will get. Now, there will be certain artifacts like ring down artifacts, blood speckle can be seen with very high frequency transducers, and motion artifacts. These artifacts are to be very well visualized, because if you try to flush it every time very nicely across your catheter, you'll be able to know whether it is an artifact or an original image. The next thing that helps us in IVUS is to identify whether it is thick, whether it is a stable plaque or an unstable plaque. Now you see the stable plaque are those which have a thick fibrotic cap. The one that you see in the center is a stable plaque. Now the one that you see in a thin cap with a lipid core, high lipid core, is something which is an unstable plaque. So these plaques are very dangerous. The thin cap plaques are very dangerous, and they have to be tackled easily and has to be tackled first. Now, for example, we know that histologically the plaques are classified into various types, and we have a virtual histology function in the IVUS consoles, in which tells us about what is the pathological intimal thickening, whether it's a thin cap fibroadenoma, it's a thick cap, it's a fibrous, it's a fibrocalcific. So it is exactly like as if you're seeing it below the microscope. Now, the next step after the interpretation of basic images, we go to the complex images, and again, the complex images also falls into these categories. Either you can see a dissection, you can see a plaque rupture, you can see a thrombus, you can see a hematoma, or you can see that you are in a false lumen. So these are the 5 basic complex images that you'll come across after the 6 simple images. Now this is, for example, a dissection. You can see a dissection has occurred because of a post-balloon dilatation, and as today shown by one of the previous speakers, a spontaneous coronary dissection can also be identified. Plaque ruptures, you can see how the plaque has ruptured over here, and it is very easy to visualize and then decide if the plaque has ruptured. Unstable plaque, these patients need to be tackled on table immediately. Thrombus can be well visualized also. You can see the thrombus which is being seen, as a result of which you can know that possibly you might have to tackle this thrombus with the thrombosuction, but you have to keep your iron, your levels of heparins well, so that your catheter does not cause any problem. The thrombus is exactly visualized very well on this IVUS. Next, this is also another case of thrombus which has been visualized. You can see a large chunk of thrombus sitting there, from which you can know that what should be the next strategy. The false and the true lumen can be easily identified, so that you can know whether your wire has crossed into the false lumen or the true lumen, and accordingly you can strategize whatever will be your next step. Next, coming to stenting and post-stent evaluation, we know why a stent fails. There might be non-apposition, there might be malapposition, edge dissection, instant restenosis, subaqueous thrombosis, fracture, and this is what breaks the marriage. And for example, most importantly, you can exactly do the sizing on the basis of IVUS. For example, if you have to take a balloon, you take 0.5 millimeter under the average of the proximal and the distal reference. So take the proximal reference in IVUS, the distal reference, and subtract 0.5 from that. If you take a cutting balloon, take the average of the proximal and the distal reference. If you take a stent, you take the average and the proximal difference average, and that is how you choose your stent, cutting balloon, or your balloon. Next, you can know the length of the diameter of the stent that has to be used. You can exactly know from the disease, from the normal segment to the normal segment, and accordingly choose your length and diameter. Now, for example, selecting the balloon size, you can see an undersized balloon was selected. Then we went to a 4 millimeter balloon. Then we went to 4 millimeter at a higher atmosphere so that the stent could be well opposed. So this is how you can select the size of the balloon. Now, instant result evaluation, especially how whether there has been proper apposition or not. For example, you see this for the first figure shows a pre-stent, next the stent, because the stent has not been expanded properly. So here you have to have a post-stent dilatation strategy, and it reveals the need of post-dilatation too. For example, we have to know where our pre-PCI evaluation stands. We can know the length, we can know the lesion diameter, we can decide PCI or not in intermediate lesions, we can decide pre-treatment whether it requires a rotablation, a cutting balloon, or a sideband protection. Then finally, after the post, we can see that the stent expansion is more than at least 90% of the average reference diameter. This has to be achieved, and you have to have a complete stent expansion, and a complete survey can be done. Now, in stenting, you can see these are cases of malapose stent where you can see there is a gap between the stent and the intima, which makes us feel that these stents need to be dilated better so that the results are much longer and best. Now, here you can see that there is a case where the stent malapposition has occurred, and if you try to flush it with saline, you'll see some saline passing between the stent and the intima, from which you can know that possibly this is a case of stent malapposition. Now, you see how the struts can be clearly visualized. You see in diagram C, you can see that as in malopposed. In diagram D, you can see totally non-opposed. So the stent struts visualization cannot be well visualized on angio, and you need to do an IVUS to know what is good. Now, here this is an opposed stent versus a malopposed stent, which can be clearly seen on the basis of an IVUS. Next, it has been shown that if an IVUS was used more than 50% of the times, you have to change your strategy, either use a larger size balloon or stent, you have to use a higher pressure, you have a long stent, and most of the times you have to post-dilate the stents because they do not have good results. In in-stent restenosis, you can also know whether how is the extent of in-stent restenosis and what has to be done and what should be the strategy. These are cases of in-stent restenosis. You can see intimal hyperplasia appearing in very low echogenicity, which is less than blood, and flushing can differentiate the tissue borders. Next, in intermediate lesions, for example, if your proximal RCA or the major branch is less than 4, so definitely you have to think that possibly it is a cause of ischemia. Similarly, in left main also, you can see if the left main is less than 6 millimeter square, it is definitely this lesion is the culprit, and you have to do your left main assessment will be proper, and accordingly you can strategize. Now, we can know the plaque composition depending what has to be done for left main. We can show what is the length of the left main, whether the left main diameter, whether the bifurcation is risk, and what's the branch integrity, and whether it is tapering or not. Now, in bifurcations, you can know about the side branch and what the strategy has to be taken. And sometimes unusual lesions, like for example, dissections, calcium, aneurysm, thrombus, as I've already shown, can be shown, and the strategy is whether it is rotational atherectomy or is it total occlusion, or the cutting balloon has to be used. The last step is post-stent evaluation, in which you see these are the various steps which I've already shown. Either is under expansion, non-apposition, or in-stent restenosis. These are the 3 things that you'll get, which has to be studied properly. Now, see, this is an under-expanded stent, which you can see the stent has to be dilated more, and the expansion is not adequate. So you have to go with a higher size balloon and do the job. Non-apposition of stents, you can see the stent is not apposed very well, so you definitely have to go ahead and you have to oppose it by again taking a larger balloon and go at higher pressures. Next, in-stent restenosis, see the soft shadow which is inside the stent. It helps you in evaluating what is to be done next. Now, if you try to see some cases, first of all, bifurcation stenting, you can see this is a case where there is a LAD and a diagonal. If you do the IVUS, you can see there is a significant plaque burden, a very fibrotic lesion, and then this is the post-stenting, and after the stenting, you can see how the diagonal LAD done by decay crush, and post-IVUS, you can see well how the stent has opposed. Next, you see this is just this imaging to show how the stent is well opposed. With this, we can call as a poor man IVUS. Now you can see both the LED and the diagonal branch, and you can see how well it is opposed the new carina that has been formed, and this helps in definitely going ahead and telling that the result has been very good. Now, if you do a bifurcal stenting, for example, here there is an ostial LED lesion, and there is a stent that you have to do also an LED diagonal. A decay crush has been done, in which you can see what is a diagonal, ultimately what is a diameter you have achieved so far as the diagonal is concerned and so far as the LED is concerned. This is post bifurcation stenting, where you can see both the diagonal, the LED, and you can see the well opposed stents and the carina that has been formed. Now, sometimes there is a lot of confusion whether you should put the stent in the LED or you should start it from the left pen to the LED. In fact, there is nothing such as ostial LED. So, always, most of the times, if you see an IVUS, you'll see that pre-stenting there is a plaque burden in the left pen, and this burden has to be tackled, and you have to put a stent from the LED till the left pen because it's very essential, and this is the result. Of course, we did an OCT in this case. We showed that there's a single stent strategy in which you can see the stent is from the LED till the left pen, which shows that it is well opposed, and we have not missed any plaque. Now, sometimes to take rota stenting from the 80 years male with angina, so you can see that these are quite calcific lesions, almost 270 degrees calcium. So these are the cases, the plaque shows a lot of calcium, so you have to go for a rota. See the amount of calcium over here, almost encircling. As a result, you have to do a rota in these cases and then put a stent in, and gives a good result. And you can see the post-stenting results where the stent has well opposed post-rota. Now, in LMCA, you should agree that definitely left main stenting should always be done under IVUS guidance, because left main stenting, if you do not do under IVUS guidance, you undersize the stent, and ultimately you land up with stents which do not get well opposed and do not get the exact MLA that is required. So you see the pre-stenting pictures of the left main, and these are the post-stenting pictures of the left main, which shows how well it has been opposed. Now, these are certain things where it can bail us out, for example, coronary dissection, edge dissections, any haziness, hematoma, perforations, identify the true and the false channels, restenosis, late malapposition. Now, a 45-year-old male undergoes a primary PC under center and then gets readmitted after 35 days. And this is the ECG which is showing again ST elevation in the infield leads. And what we saw on the IVUS was that the stent had thrombosed. So naturally, when we did an IVUS, what we saw was that there was some intimal hyperplasia, there was a ring calcium, and a non-opposed stent. So this is one of the commonest cause of non-apposition or stents which leads to subacute thrombosis. Now this is what we did. We just did a post-balloon, just a plain ballooning, and you can see how well the stent is opposed now, and this helped us because of IVUS. Now this is the final IVUS pictures where you can see the optimally opposed stent and how well it has been opposed just by a simple dilatation with a larger size balloon. Now, it has been shown that stent under expansion and residual reference segment stenosis are related to stent thrombosis, and this has been well proved in a lot of studies. And if you see that if you use IVUS, the incidence of stent thrombosis is very low compared to that if you don't use IVUS. Now, a BVS which had been used after 3 months, the patient comes with strongly positive TMT. You can see that the BVS was used, this thing that is to the LED. You can see now this was the initial case in which the BVS was done. Then the patient comes with a positive TMT, and now you see the circ ostium is diseased. So now this was the reason for angina and the TMT being positive, and here we did an IVUS and saw the L6 ostial had quite a very high plaque burden. And this had to be, we had to do a culotte in this from LMCA to LED and LMCA to circ to complete the job, because only putting a stent from LMCA to circ would not have done the job. And the BVS was there, which had already caused a plaque in the circ. So this is the post-culotte images where you can see the LMCA, you can see the LED and the circ, and you can see the circ also. And the final images are very good compared to what it was in the beginning. Now, while doing the pot, you can see a dissection has occurred, and this dissection can be very well visualized. On a left main pot was being done, and you can see the dissection, which was only visualized in the cranial view, and the IVUS images helped us. Sometimes subintimal wires can go, and this can help you in re-going into the true lumen, especially in CTO cases, where you can see pre and post PCI when the wire strategy was changed, and then it was only IVUS guided. Next, sometimes perforations. For example, this is a case of LAD and left pin lesion, which was being done in a very young lady, and you can see what happened while doing the pot. The IVUS evaluation showed there was a significant left pin plaque along with LAD, so it was planned to do a stent from LAD and then again the LAD and the left pin. So after the left pin stent was put, a 418 JDS was put, it was done post-cutting balloon, and then you can see the IVUS of the LAD that needs a little bit of more post-dilatation, and see what has happened. The full thing has perforated, and the whole left pin perforated, and the lady started sinking. And then what we did, we put a covered stent, in fact, post-perforation. We took a covered stent, and after we put the covered stent, we also saw that the leak was still ongoing. So this made us think that now it's high time we should know what's going on. What we saw on IVUS was that the cover stent was not well opposed to the original stent. So what we did was just, you can see the two layers of the stents, and it was just a lot had to be achieved, and we gave a very high pressure dilatation, after which it worked, and finally the result was that the plaque which had ruptured could be sealed and the patient could be saved. So sometimes in such situations you have to go inside and see in complications how the leak is saved. Now, choosing the right size of the stent, for example, what will be the stent for this size? For example, this looks quite big, there is some thrombus, and pre and post PCI, the renal stent has been put in this case. Similarly, in this case, the artery looks something like 4.5, but usually don't get such size stents, so we have to size the stent on an IVUS, and then you can see putting 6 mm renal stents, 2 stents have been put, and you can see the final images. There's no harm in putting renal stents because renal stent struts are much thinner than the VVS struts, and they can be easily used in the coronaries. Now, sometimes the smallest stent, you see this looks like a thrombus. Now, the smallest of size balloon did not cross, and when we did an IVUS, we could see that there was a large chunk of calcium for which we had to do a rota in that case, because a rota was very much essential. And after doing the rota, it was very easy to put the stent inside and finally complete the job. What looked like a thrombus was not a thrombus exactly, but was actually calcium. Next, bailout case in a case of unstable patient, a dissected artery. You can see this is almost a subtotal RC occlusion, and just when the guiding was put, there was total occlusion, the patient went into complete heart block, and then immediately when we crossed the wire, we saw that we had gone into the true lumen, had gone to the false lumen, and again into the true lumen. So this is what has happened. This is the true lumen, and this is the false lumen, and this helped us in, through IVUS, we could know that it was a true, false, true lumen. So it was easy for us, and then either there were two options, either to again rewire through the true lumen, or just go along and do this thing, stenting across. This is what we did. We somehow did from the stent, put the stent from the true to the false, through the true, and ultimately the result was very good. We compressed the true lumen, and this was the final result. And what was very interesting was that when we did the post-IVUS pullback, we could see that the stent had been well opposed, and there was no issue at all, and the patient was doing well. So this was the pre and the post findings, because the patient had crashed on table, and IVUS helped us in bailing out this patient by tackling this complication. Now, why did not try to again rewire that? Because you see this was basically the side branches were preserved to my good luck, and there was no need to bail out, no need to again recross the true lumen, because it was just a bailout situation, and so the patient could be saved. Now, this was the reason why I didn't do that. Now, the lucky case, the most 13th case that I'll present, you see, this is a BVS to LCX done 1 year back. First starts with exertional angina. You can see some amount of calcium and fluoro, but the angio was not very significant. But when an IVUS was done, you could see a significant chunk of calcium. In fact, we used a cutting balloon. You see with the cutting balloon, you can see the cut seen on an OCT, and then put a stent from left pen to the LAD, and finally the results were good. So this was the pre-IVUS and the post-IVUS images. So has IVUS surprised you regarding its importance in PCI? Definitely no. If your only hammer is a tool and you start nailing it, definitely would injure yourself. So it's better that you have to do intravascular guided stenting does improve as per the reports that has been published. There have been 7 studies in BMS and 11 studies in drug-eluting stents which have shown that IVUS is better, and definitely you will all agree that you only see what you look for, and you only look for what you know. If you do not know, you will not be able to know. So let us not have a narrow vision anymore. So in all cases of PCI, what we do, for pre-evaluation of vessel size and lesion length, we use IVUS. Post-intervention, we try to see whether there's expansion, apposition, coverage, complication, or under-expansion or edge problems. This is what you see. Now, if I audit my practice of IVUS, we got IVUS around 4 years back, and we have almost been doing IVUS, and more than 54% of the cases have been IVUS, and lately, after February, we have been seeing that we've been picking up still to more than almost 75 to 100% of the cases, we are doing imaging guided. Now, you should all remember that never be afraid to try something new. Many people have problems in putting an IVUS catheter in a complication, but you remember that amateurs build the Ark and professionals build the Titanic, and the Titanic sank. Thank you all for your patient hearing.
Thank you very much, Dr. Prasanth Kumar, for your elegant lecture on IVUS. Actually, you gave a lot of information within short time, right? It's very useful for our new cardiologists, basically. We are now more frequently using IVUS in our Sri Lanka. So thank you very much again on behalf of Sri Lanka Heart Association. I cordially ask you to come for a token of appreciation. Thank you.
Thank you, sir, and thank you, chairpersons. Ladies and gentlemen, we have a slight change in our program. We are moved up with the interactive session, that is the ECG quiz now, which will be followed by the planned lecture afterwards. The ECG quiz will be moderated by Dr. Susita Amrasinghe and Dr. Amit Vora. The panel, Dr. Asunga Dunavilla, Dr. Rohan Gunawardana, Dr. Mevan Vijayatunga, and Dr. Bogan Nuta. We kindly request all of you all to utilize the response device for the first part of this quiz, which will be conducted by Dr. Amit Vora.
Good evening, everybody. Thank you very much for staying in here till the end of the sessions, despite it being a busy Sunday evening. And we have come to the last sections of the event. And I would, at the outset, like to invite all of you to come forward, come and sit forward here, so that we can make it actually an interactive session. And it's not going to be very complex electrophysiological stuff that we are going to discuss. We are only going to discuss the basic principles of interpreting ECGs. So this session we are going to carry out in 2 steps. The first part, Dr. Amit Vora will be conducting using the audience response system. The second part I will be carrying out without the audience response system. And we have a panel of experts, of course, who doesn't need introduction. You all are very familiar with them, Dr. Sangdunavila and Dr. Rohan Gunawardana, as well as Dr. Bogdan Nuta and Dr. Mevan Vijayatunga. So I would invite Dr. Amit Vora to kindly start the session.
Thank you, and thank you for also accommodating, because I need to catch a flight, and we will have ECGs come up and give you a brief story behind the ECG. Essentially, some of them are recognition of patterns, so there might not be much story. So this is the first ECG where there is bradycardia, and you need to answer from this ECG what is the cause of the bradycardia. Is the bradycardia because of sinus node dysfunction? Is it sinus bradycardia? Is it purely because of a left bundle branch block? That is your option B. Option C, is there an AV block? And option D, the bradycardia is likely because of some drugs. So use your voting meters, start voting, and I guess we should be able to see the number of people voting up there. So it is a slow rate, wide QRS, and you need to identify the cause of bradycardia. All right, can we have the bar coming up as to what is the choice people have taken? So left bundle branch block and AV block.
are the ones which are most prominent. Can I have any of the experts give us some clue as to what do you think the bradycardia is due to? Are we able to see the ECG well?
Shall I take this? Thank you. So, first of all, the left bundle branch block is very clear. The traditional teaching would tell us that we need to look for the P waves in a lead that we can see them best. And in essence, if you look at lead V1, I think that there are 2 P waves for every QRS.
Absolutely. Can we have the next slide come up? Okay, and I will click here also. All right. Okay, so this is what the expert said, that look at the P waves in lead V1. So V1, AVR, these are often neglected leads whenever you want to know the rhythm. Look at these leads. They can show the P waves very well. And here you can see that the P waves are quite well timed out in terms of there are 2 P waves for 1 QRS. So this is a 2:1 AV block with left bundle branch block, right?
One caveat to this is this could have been complete heart block.
Yes.
But the atrial rate was exactly half the ventricular rate, and the PR interval just happened to be caught at the time. It is absolutely equal. So I think a differential here would be complete heart block, but it looks like it's second degree.
Absolutely. So you need to see the ECG on a longer period of time, because often in a given 10-second strip, you might mistake this as a 2:1 AV block, but it might be really a high-grade AV block. So what is very important is when you want a rhythm diagnosis, lead 2 is what is commonly looked for the P waves, but V1 is a neglected lead. Look at that. Any sharp or a high frequency signal on the T wave is slow undulating waveform, should make you suspect that there is a P wave within the T wave, and a bundle branch block with 2:1 AV block or a high grade AV block would mean that it's an infraesian block necessitating a pacemaker implantation. All right, this is second ECG of a 54-year-old gentleman who has come to the emergency with acute chest discomfort. And in the ER, you're looking at this 12-lead ECG. And, you know, it times is important how quickly you act and with what armamentarium you act. So to be able to know from the ECG whether this is some patient who is at high risk or low risk, risk stratification becomes important. Does this ECG guide you that this is an ACS because there is ST segment shift, but do you think it's a low risk acute coronary syndrome? Is this a high risk acute coronary syndrome, or you think the ST segment shift is because of pericardial diseases? Or you think this ECG is normal and the patient can very well go home? Take your pick and let's analyze this ECG. We have a fair number of people who have put their choices. Let's have their answers. Vast majority have said high risk ACS, and I'm very glad for that. Does anyone want to volunteer that what is there in this ECG ST segment shift that makes you suspect that this is a high risk ACS? When we say high risk ACS, that means large myocardium is at jeopardy, and what ECG clue here tells you that it's a large infarct in evolution? ST elevation in AVR, wonderful. ST elevation in AVR. So AVR, V1, these are the most basal leads, and if they show ST elevation, that means that your infarct vector is pointing upwards, and this was the angiogram. It's a very, very proximal, tight LAD stenosis, large area of myocardium at jeopardy, and Professor Wellens has been able to make us understand very well in terms of left main versus proximal LAD or a mid LAD disease. And here you can see if you have a left main disease, your ischemic vector is pointing upwards towards AVR and AVL. So AVR, AVL, V1, all of these leads will show ST elevation. But if you have only a proximal LAD occlusion, proximal to the septal, often you can get a right bundle branch block and the ischemic vector is still directed towards AVR. So often in the inferior leads, in a proximal LAD, you see an ST depression, not an ST elevation, but it's a mid-LAD occlusion which the ischemic vector facing downwards may give rise to an ST elevation in the inferior leads. So this is a classic ECG of a left main stenosis where most leads, almost all the leads show ST segment shift, but majority of the leads show ST segment depression and only few leads show ST elevation. And in this case, it's classic AVR and V1 which show ST elevation. So this was a proximal LAD and I'm glad that you all could pick that up. All right, we move to ECG number 3. This is a narrow QRS regular tachycardia in a young person, and it's relatively easy to be able to say that what is this narrow QRS tachycardia, and your choices are A, atrial flutter, B, it is a atrioventricular nodal reentrant tachycardia, C, it is a sinus tachycardia, or D, an atrial tachycardia. Please vote. All right, this should be more like a spot. So let's have the voting meter results. And we have AV and RT. Can you please explain that what is your opinion and what do you think is going on here? What is the most likely reason for this narrow QRS tachycardia?
So, I don't see a classical atrial flutter here in terms of sawtooth pattern. I think exclusion
Can
was...
you take away the
exclusion was not that difficult. With regard to AV and RT, I would disagree with the majority of audience for the reason that AV and RT, by virtue of it originates close to the AV node. So when the tachycardia comes from the bottom of the atrium, the atrial activation is from bottom up. So if it's a bottom up, inferior leads 2-3 AVF should have a negative P wave, and you don't see that. So that's one of the easy way of ruling out AV and RT. And you see that in lead V1, you have a clear P wave there, I would say, right? That's a P wave, that's not
Absolutely.
a T wave.
Absolutely.
Yeah. So that's a biphasic P wave. And so I would assume corresponding to that, there should be a negative P wave in 2-3 AVF, should it be AV and RT. But what you see is a positive P wave. So that excludes AV and RT for me. So that leaves me with two options, either it's sinus tachycardia or atrial tachycardia. Given the patient is young, I would still vote for, I mean, it could be sinus tach depending on the clinical history. I don't know whether the patient had fever or some other issue. Because the P wave in V1, if you look at it, it's biphasic, and it looks like a sinus P. What would you expect, right, usually? Do you agree, Dr. Bora? And so, but there's a little longer PR interval than usual. Or whether it could be atrial tachycardia coming close to that area is possible too.
Yes, absolutely. So if I were to tell you that this was a persistent rate all through the 24 hours, without any fluctuation even at night time or sleep or with rest, that would make you highly suspect that this is likely to be an atrial tachycardia. It's often difficult when the P is merged within the T wave to know the morphology clearly, but yes, on a bedside you could try some vagal maneuvers or even a AV nodal blocking drug to see whether you can identify the P wave well. But V1 is the lead which showed the P waves the best, where the RP interval is long. So the differential obviously is in terms of atrial tachycardia and sinus tachycardia. This was a 10-year-old girl who had actually presented with heart failure, and the ECG was rock steady, similar for last couple of months. despite being on anti-failure medications which the patient was put on. And eventually we did the EP study, and we found out that it's a high crystal atrial tachycardia which was ablated and the LV function reversed. So this was an example of an atrial tachycardia induced cardiomyopathy.
Just one very quick point. One of the reasons why this would not be typical of AVNRT, one of the hallmarks of AVNRT is the R prime in V1, which would be absent in sinus rhythm. So you may wish to see an ECG in sinus rhythm, although there is no clear-cut evidence of R prime in V1. At the second point, if this were sinus tachycardia in a young patient, you'd expect a much shorter PR interval. So I think for those reasons, this would be highly unlikely to be either of those.
Certainly. So here you will definitely not think in terms of a typical slow-fast variety of AVNRT. The differential would have been the atypical variety where the RP interval could be longer, but very rightly you pointed out that it should show an inverted P wave in the inferior leads, which is clearly not showing. So making atrial tachycardia a very likely diagnosis amongst the two. You can see the QRS alternans in lead V4 also, and here alternans is most often seen in patients with rapid tachycardias, but also can happen with LV dysfunction. This child had an ejection fraction of hardly 15%, and that was the reason of the alternans. All right, I would, in the interest of time, skip this ECG and go forward and show you a couple of them which are more, I think, important, relevant. So this is a Holter monitoring of a 38-year-old lady who's hypertensive on amlodipine, who's been off late complaining of paroxysmal palpitations, and her echo is reported to be normal. Now, because of the paroxysmal nature of palpitations, they were frequent enough, a Holter monitor got done, and this is what the Holter strips show. So now the question to you is, how would you approach this patient? Hypertensive, known to have normal echo, palpitations, wide QRS tachycardia picked up on Holter. Would you like to do A, electrolyte testing, whether this is hypokalemia, hypomagnesemia, B, you would like to rule out ischemia and ask for an angiogram, or C, let's do an EP study, find out this reason for wide QRS tachycardia and try to sort out, or D, you'd like to do a further investigation in terms of finding out what is the reason for this wide QRS tachycardia by asking for a cardiac MR. So kindly choose, and then we'll have the experts analyze this. All right, let's have the voting meter on. Electrophysiology study. So, Asanga, everybody is saying EP study. What would you do an EP study right away?
Yeah, I guess so. Yeah.
You think so?
Yes.
So, any difference of opinion from the panel?
Well, the explanation is that there's a wide QRS tachycardia that is going on with wider base, and it shows slight irregularity. So it's in favor of atrial fibrillation, really, when it breaks through. Then in a young patient, if you feel that he's having fast atrial fibrillation, one would start looking for a WPW. So
I would like to really calculate.
I
would like to calculate the QT interval here. The corrected QT.
So you would look for something like that.
Okay, so I think what is important is you have this Holter rhythm monitor, but a 12-lead ECG is very important. So a 12-lead ECG showed sinus rhythm with no pre-excitation pattern. There was very mild LV forces, and the QT interval was normal.
One other possibility would be that it is an atrial tachyarrhythmia, possibly atrial fibrillation with rate-related aberrancy, and usually when tachycardia goes past the AV node, the right bundle branch block occasionally gives up the ghost, and you end up with bundle branch block aberrancy, which is rate-related. So it is possible that this is a paroxysmal atrial tachycardia with rate-related aberrancy.
So we were, I don't have the ECG, but we were fortunate enough to get a 12 lead of this wide QRS tachycardia, and the morphology characteristics were classic of a atypical, not an idiopathic variety, but atypical location of a ventricular tachycardia. The wide QRS was not in keeping with any bundle branch block pattern, and also there were pointers clearly on a 12 lead to say that this is a ventricular tachycardia. So now, if I say that this is a VT, what would your approach be?
Well, I think first of all, again, the question of whether it's a VT is there, because of this slight irregularity. I think again the possibility that it may not be VT is there if you look at the ECG, if you just look at the ECG. Right? So true, when you go back or you go forward and you do other studies, you do the 12-lead ECG, you might come to a different decision. But initially, when you look at it, I think the fact that there is some irregularity, you have to think of atrial fibrillation with a bundle branch or some kind of aberrant conduction in the initial stage. I don't think we can conclude that this is a VT just by looking at this particular hole.
I agree with Rohan. Now, you mentioned that you had another 12-lead ECG that suggested, so based on suggested VT. So assuming that was VT, if that's the case, in a young woman with a ventricular tachycardia of unknown etiology, I would go for a cardiac MRI scan to see whether there's any, because it's an unusual VT you mentioned, so you had the opportunity to see the VT, and why is that? So would it be some sort of infiltrative heart disease, some sort of cardiomyopathy, something going on? And that's, I would look into first, and then based on that, you take action.
I think over the years, we have become wiser in terms of young people with a normal echo, but presenting as a wide QRS tachycardia, which looks like a ventricular tachycardia, in terms of not getting an EP study and ablation done as the first step, but looking at further cardiac imaging. And in this part of the world, we see this often. So this lady was subjected to a cardiac MR, which showed a late gadolinium enhancement, and in fact had interstitial lung involvement. Mediastinal lymphadenopathy was there. It was non-caseating granuloma, and eventually turned out to be sarcoid, which was treated, and she is with a preserved ejection fraction on amiodarone and beta blockers. We are following up. She's doing well on antiarrhythmic drugs, and she's been continued. But it's always an open question that the reliability of EP study is not very high, but at some point in time we do feel to do an EP study after the acute period is over, or immunosuppressive therapy, whatever has been given, to do an EP study to see inducibility and decide the need for an ICD.
Just out of interest, was that the only broad complex tachycardia that you saw in that patient on a Holter? With sarcoid, usually you see different morphologies of non-sustained VT, not just a single morphology, because of the degree of involvement and fibrotic changes. So was that the only type of broad complex tachycardia that you saw in that patient, or were there any other runs?
So so the morphology also kept on varying. We had, it was, to define it, it was like a pleomorphic VT. You had multiple morphologies of monomorphic pattern happening on a longer term monitoring eventually. That's what we saw in this patient. So I think it's important to have a low index of suspicion in people with ventricular tachycardia, which is not of a typical location, to look for sarcoid. I think we will move on to a couple of more ECGs. All right, so I think this should be simple and straightforward. You have a 12-lead ECG of a very wide tachycardia. What would you call this? Is this a monomorphic VT? Is this a polymorphic ventricular tachycardia? Is this WPW with atrial fibrillation? or it is atrial fibrillation with a bundle branch block pattern. Pick your choice and we'll have the experts help us. All right, let's have the audience poll, and there have been few people who have said that it's monomorphic VT, some have said polymorphic, but the majority say it's AFib with WPW. Ron, you take?
Yeah, I think it's quite clear here. You have broad complex tachycardia, which is irregular, so that itself, so any tachycardia, particularly broad complex tachycardia, which is irregular, you have to think of atrial fibrillation, because most of the VTs that we see are more regular, right? It doesn't have a typical bundle branch block pattern, so it certainly doesn't have a left bundle branch block pattern, so it is therefore most likely the conduction down the WPW, so that is probably why you have that. And if you look carefully, if you look at V5, is it? I can see, yeah. Yes.
Can you remove the voting bar? Yeah.
So if you look at V5, you can see that there's kind of, you look at it, there are delta waves there with a broad base and going up, so that again makes it more likely to be WPW with atrial fibrillation.
Absolutely. I think this is a pattern recognition which you should ingrain yourself. If you have a very fast tachycardia, if you have a broad QRS, broad bizarre QRS, and irregular tachycardia, it is FBI, as Dr. Wellens taught us, and is a kind of pathognomonic of atrial fibrillation with WPW. Because with atrial fibrillation, the axillary pathway has the ability to conduct very rapidly, and therefore the RR intervals are pretty short at times. And the nature being monomorphic or polymorphic, I think this is often a confusion I also see people making. When you define monomorphic, beat to beat, the morphology should be same in that given lead. So in one lead, whichever you see, if you have the same pattern, you would call a monomorphic tachycardia. And if in that same lead, if the morphology is changing, then you call it polymorphic tachycardia. So this is clearly, we can see that bottom is the rhythm strip. It's clearly a monomorphic variety of tachycardia, but irregular. The hallmark of irregular is an atrial fibrillation. And obviously, as Ron rightly pointed out, there's no question of bundle branch block. It's too rapid, and it's a AF with WPW and should be subjected as early as possible for radiofrequency ablation, because these people can have syncope and sudden death. I think I'll wind up with this last ECG because it's interesting. It's a 56-year-old who'd been complaining of dizzy and fatigue feeling. He has a history that his brother was implanted with a pacemaker for sinus node dysfunction, and he has presented now with this bradycardia. So this bradycardia could be because of A, sinus node dysfunction that he also has, B, there is an AV block, C, there is hyperkalemia, D, it's just a sinus arrhythmia. And sometimes these ECGs can be difficult, and unless until you know the entire story, it's always difficult. But nonetheless, it's an exercise in trying to logically come to a conclusion. So let's have your votes, and once we cross the figure of 50, we'll start looking up at the answers. Can we have the bar diagram? Sinus node dysfunction and hyperkalemia. It's a tough one. I think, can you take away this bar diagram? There is sinus node dysfunction, the way there is no P wave and there is a long pause with a junctional escape rhythm that is happening. But what is intriguing is that you are seeing very peaked and tall T waves in V4, V5, V6. So when you have this, it's prudent, as though it might be a sinus node dysfunction. The question is it primary sinus node dysfunction, or is it due to any other electrolyte or metabolic imbalance? And in this patient, in fact, we had potassium of 7.2, and after correction of hyperkalemia with glucose, insulin infusion, soda bicarb and calcium gluconate, in a matter of an hour or so, couple of hours, the ECG completely normalized, the sinus rate improved. So metabolic problems can fool you in various ways, and we should have a high index of suspicion in ruling it out. And we tried to find out why this gentleman had developed hyperkalemia, and it's that he had started, he was taking excess of coconut water and fruits as a form of diet therapy, and he was getting into mild hypertension, so he's taking some alternative medications also, which we don't know what consisted of, but this is what we saw. I think I'll conclude here, and thank you very much for your patient listening. Thank you.
Thank you very much, Dr. Amit Vora, for that excellent case discussion. And also thank you for being with us, taking all the trouble to travel here. I would like to invite Dr. Asunga Dinuila to present the token of appreciation to Dr. Amit Vora. Can we have the next presentation there, please? Thank you. While we are getting ready, can I ask you all, what does the acronym ECG stand for? The acronym ECG stand for? Silence. Well, I always thought it's electrocardiogram, but someone enlightened me recently telling ECG actually stands for extra confusing Greek. So maybe it probably is more appropriate looking at the previous ECGs. Right. Let me go through a few of the slides. Depending on the time we have, I will be skipping some as well in the process. So, okay, these are quite basic ECGs. This is all these patients are from down south who have presented to Karapiti Hospital to our unit over the last 3 months or so. So maybe 6 months. Last 6 months. Yeah. So this was an 86-year-old female, non-hypertensive, has had several episodes of pre-syncope over the last 1 month, and this was the ECG. So what is the diagnosis? Quite straightforward diagnosis. Complete heart block, second-degree heart block, sixth sinus syndrome, atrial fibrillation. Of course, we have, to save time, we will not use the ARS. Like the old fashions, shall we raise the hands and show some interactions, please. So I'll show you the ECG again. Obviously, it has bradycardia, so I will not be discussing tachycardias here. So the diagnosis, is it sixth sinus syndrome, or SA nodal disease, AV nodal disease in the form of complete heart block, or other degrees of AV block, or atrial fibrillation? Answer one? Excellent. So yeah, most of you agree. Fine. So this is after the management. Anybody who can answer? I'm sure people. Remember, this is an 86-year-old female, so we did not go for any hi-fi devices. She was just managed with a VVIR, PPA, permanent pacemaker, pacing the ventricle. She went home fine. So this is the second patient we have. Somewhat similar to the ECG you just heard from Dr. Amit Vora, a 54-year-old male, farmer from Ampara, came with several episodes of syncope and found to have this ECG. You can see, so have a look at it. I'll give 20 seconds. Again, the same differential diagnosis. Is it SA nodal disease, complete heart block, second degree AV block, or atrial fibrillation? Yeah, it comes excellent. Yeah, so it's an interesting ECG. This patient was very heavy manual work actually. He completely became incapable of doing anything because once he developed this condition. So he doesn't have any proper P waves. If you analyze the P waves here, they are all abnormal and clearly showing that they are not arising from the SA node. So he has, his SA node is not functional here, and most of his atrium was not functional. He was just running with this ectopic atrial rhythm with a completely silent SA nodes. So this is after his management. So anybody who can.
I was just going to make one point about the previous ECG. In a 54-year-old, that degree of sinus bradycardia tends to be quite unusual, certainly in the Western world. So I probably would have checked the thyroid function before doing anything else. But
of course, we have excluded all the reversible causes, including all 4 electrolytes and thyroid functions, which are normal. To save time, yeah, that was assumed, yes.
So it's a point of interest. Now, he was really bradycardic. It looks like sinus node disease. Yes. And also, it was very regular in bradycardia. Sure. So that when we, I think about the sinus node disease, we probably also need to think about hidden AV nodal disease, just to highlight the point.
Yeah, that's a very good point, sir. Yeah, I completely agree.
It's very masked because of the
in fact, disease. Yeah, that's a very important point for management as well. So he being a 54-year-old male, we would always prefer a dual chamber pacemaker. But in the government sector, we only have single chamber pacemakers most of the time, liberally to use. In this patient, by the time we were managing this patient, we didn't have any dual chambers. So what we did was we did a basic Vencubac test to check the AV node. His AV node was absolutely good, fine. Therefore, we went for a atrial only single chamber pacemaker. I know you will have different opinions. I didn't want to go for a single chamber ventricular pacemaker here. He's a manual worker. He's doing very well. Unfortunately, in the process before the pacemaker, actually, he had a stroke. So that was rehabilitated because he had atrial fibrillation transit episode, second to the bradycardia. After that, he was fine.
Can I just make a comment on this? I mean, it's very easy when you look at it, these ECGs say this is complete heart block or this sinus node disease. But I think still a lot of clinicians find it difficult to make the differentiation. So important and useful rule of thumb is that if you see more P waves than QRS complexes, it is likely to be AV node disease, and vice versa. So that's something that still we do get referrals where we say, oh, this is complete heart block, but it's not, and other way around. So that's just a kind of very small point to make that you see. So in your early ECG with the complete heart block, there are many more P waves than QRS complexes, and here you don't see any. It's just that there are P's are very, very slow.
Sure.
And one other just very brief point. Once the pacemaker is implanted, same as you would have implanted a dual chamber pacemaker, I presume that you would routinely extend the AV interval to prevent RV pacing in a 54-year-old.
Exactly.
To prevent cardiomyopathy.
Exactly. Even if you have dual chamber, we will try for it to get paced in the atrium only whenever possible. So I think in the interest of time, we'll have to limit the ECGs. Okay, this is very recent one, just 2 weeks back or 1.5 weeks back. The patient presented to Dr. Sadanandan and Dr. Bhati Ransingh's unit and referred for the management. A 32-year-old female, history of generalized body weakness and urinary symptoms. That was 2 weeks back, the current presentation to a peripheral hospital, and she this time was transferred from the same hospital to us because she became unwell again, presented back. And on admission to teaching hospital Karapita, this was the ECG. Have a look. This is an interesting case, I must tell you. So the answers are, before I go to the answers, actually, I'll show you the ECG in sinus rhythm once that rhythm was terminated using DC shock. So this is the sinus rhythm ECG that patient had. On admission again, because patient was not tolerating that rhythm, we had to cardiovert the patient. And the question is, what is the primary investigation of choice here? A 24-hour Holter, cardiac MRI, coronary angiogram of electrolytes, or serum electrolytes, yeah. So we'll go back to the ECG. Would anybody want to comment on this? This is a very interesting patient. She's still there, actually. We are managing her with multiple challenges. Exactly, sir, yeah. And low voltage ECG, especially you can't see the QT interval well defined with a very low amplitude T waves in most of the places. In fact, in some of the chest leads and limb leads, some of the limb leads, T wave is almost not to be seen. And of course, the rhythm, this rhythm, of course, I'm sure you will not have no doubt. This has critical features or cardinal features of a VT, very clear AV dissociation for the doctors who are not very familiar with looking at a broad complex regular tachycardia. So this is a broad complex regular tachycardia, however, without the classical precordial pattern of precordial transmission of the QRS complexes. So there's a negative concordance on all chest leads. And also, if you look carefully, you can see dissociated P waves, as well as compared to the normal sinus rhythm ECG, morphologically as well as axis-wise different ECG. So it's a ventricular tachycardia. Now we know, obviously, there's some abnormality in the T wave. So the first thing you would definitely invariably do is electrolytes. In this patient, what is unusual was she has had a cardiac arrest 2 weeks back also, and all 3 electrolytes were actually low. Serum magnesium was very low, and serum calcium was again low, and serum potassium was also low. So she's under the care of endocrinologists as well as the cardiac team, and being evaluated for metabolic disorders, which has led to this. The only significant history she gives is she has had a urosepsis, pretty bad urosepsis. That's when she had the first episode of VT and arrested.
Just a comment on that. I'm not quite sure what the ejection fraction of 30% fits in.
So the ejection fraction we had was after the first cardiac arrest, and it was 35. When we reviewed the ejection fraction, it was about 40. Yeah. There was some slight elevation. Of course, we have not ruled out a coexistent dilated cardiomyopathy process, so she is still under evaluation. But it doesn't really explain the significant electrolyte abnormality alone. Do we have any time left? Or shall we call it a day with the ECGs? Do we have time? Yeah. So therefore, in the interest of time, I would like to thank all the experts who have helped with the ECG quiz, as well as the audience who participated with actively. Thank you very much. I would like to invite Dr. Sangudunavila to accept the token of appreciation. On behalf of? Yeah. Thank you very much.
Thank you, sir. Special announcement, if you are having the response devices which was used for the ECG session, please hand over it to the organizing committee. And also, next, moving on with the schedule, it is a case-based discussion on atrial fibrillation. Co-chairs will be Dr. Anindu Patirana and Dr. Dhananjani Senaviratna.
Good evening. So we'll move straight on to the final segment of the sessions. Dr. Borden and Rohan will conduct the discussion. Over to you.
So the next few minutes, we are hoping to discuss something about atrial fibrillation, using a case as a basis of our discussion. And hopefully we'll cover some important areas in atrial fibrillation which are always somewhat confusing and which will be hopefully useful for the audience. So Bogdan, can I, without any further ado, can I ask you to start the case?
Could we have the presentation, please, the slides for the case-based discussion?
Can we have the presentation, please?
Yes, there is a presentation downloaded. The slides are white. I must say, this is the first time when the technology breaks down. It's been absolutely superbly organized. Fabulous. Thank you. I knew you wouldn't let me down. So without further delay, let's go into the cases. There seems to be some difficulty moving the slides, so can I go on? Excellent, thank you. So the first case, which is the only case we will be discussing today because of time constraints, this gentleman was 67 years of age, and I first met him in 2008 when he presented to hospital in heart failure with an ECG documenting atrial fibrillation with fast ventricular rate. Of course, we started by treating his heart failure. Next, we moved on to see what the etiology of the heart failure was, apart from the atrial fibrillation. We looked at his coronary arteries. They were entirely normal. We did consider a cardioversion whilst he was in hospital. The problem was that he was not anticoagulated at the time because it was his first presentation of heart failure. And in fact, we talked about having a cardiac resynchronization device if our treatment with heart failure did not improve his airway function. I have a feeling that this is not the correct sequence. Yeah, I'm clicking. There's no problem, but it's not working. Can we go to the beginning of the presentation, please? Thank you. Thank you. Sorry, we are getting there. Right, okay, so the mouse was too far away. I can talk about the case without showing you the slides if it makes it easier. So we have a 67-year-old gentleman who presented in 2008 with heart failure and atrial fibrillation. His ventricular rate was well in excess of 120 beats per minute, and he had typical signs of heart failure. We treated him with diuretics, we treated him with ACE inhibitors and beta blockers, and we planned an outpatient cardioversion, having established that his coronary arteries were entirely normal. So, in terms of possibilities of the etiology of his heart failure, we know that it wasn't coronary disease, and we felt that it was entirely possible that this is a tachycardia-related cardiomyopathy. Thank you. Having treated his heart failure, we documented that his ejection fraction in sinus rhythm improved to 40%. So although we had a discussion about cardiac resynchronization therapy, this did not appear in any way necessary at this stage. And I'm delighted to tell you that 9 months later, he was back to normal activities, he was in sinus rhythm, and he was playing tennis. At this point, he was still on anti-failure medication, he was taking amiodarone, and an ejection fraction was quoted at 58% with a normal-sized left ventricle, having cardioverted him from atrial fibrillation. Rightly or wrongly, and I'm sure it's not right, we, at that point in time, stopped his warfarin. This is quite a long time ago, before the CHA2DS2-VASc score was maturely in place. But we continued his anti-failure medication, and we kept him on amiodarone for another 6 months. That was the plan of action.
Could you just go back to the first slide, Bogdan? Yeah, so I mean, at this point of presentation, one thing I think, one question we would probably want to know or think about is, this is a patient presenting with the first diagnosed episode of atrial fibrillation. So in this situation, is this just paroxysmal atrial fibrillation, or is this a persistent atrial fibrillation? I think that's a question that we might at that point think about, right? The fact that there is some LV dysfunction, and if you are assuming that the atrial fibrillation per se led to that LV dysfunction, then we would probably think that this is more persistent atrial fibrillation, so that this is actually a tachycardiomyopathy which has been caused by the atrial fibrillation. Now, one question I would like to kind of ask is, now, this patient is present with heart failure. So in that situation, would there be would you consider convert it to sinus rhythm fast, like an urgent cardioversion, because the patient is in heart failure, maybe hemodynamically unstable? Would there be an indication?
Very good question. Of course, he presented in heart failure, but generally speaking, for someone to develop heart failure in the context of AF with a fast ventricular rate, that process has to occur over a period of time. This patient, on admission to hospital, was not on anticoagulation, and it was not possible to establish whether his atrial fibrillation was under 48 hours duration or over 48 hour duration. The likelihood is that he was longer standing, at least a few weeks. And secondly, he was hemodynamically stable. So we did not cardiovert him because he was stable, and we did not cardiovert him because he was not on anticoagulation at the time. We could have done had we performed a transesophageal echocardiogram, but we did not feel that it was necessary to do so in the presence of clinical stability.
If a patient did come with hemodynamic instability in atrial fibrillation, and you didn't really have time, or you had no facilities to do a TOE, would you still cardiovert?
Sorry, I missed the last question. So if we'd done a TOE, would we have changed the management?
Well, in the sense that if you didn't have a TOE to decide whether there was any intracardiac emboli, would you still cardiovert if you didn't have the facilities to do a TOE?
Yeah, if we'd had a TOE available and if the patient had been in any way compromised or struggling, then we probably would have done. We have done on many occasions previously. So as I said, 9 months later, he was doing remarkably well to the point where we stopped the warfarin because he had a normal heart. But we kept him on anti-failure treatment and amiodarone for another 6 months.
Yes, I think stopping the warfarin would have been a question because we don't know whether this is a paroxysmal atrial fibrillation. We know that the risks of thromboembolism is still the same, whether it is paroxysmal or not. Now I think we all accept that we use the CHAD-SWAS score as a guide for us to start on anticoagulation. And would you say it's a robust tool to be used in deciding whether the patient needs anticoagulation? Would that be something that we should all be using routinely as a means of deciding whether the patient needs anticoagulation?
I think our judgment retrospectively was probably incorrect at the time to stop the warfarin because the atrial fibrillation wasn't going to go away. I think our judgment was skewed because his left ventricular function was normal and he was just over 65 years of age. So we felt, rightly or wrongly, that his risk of a stroke was going to be low. But clearly we weren't 100% confident, which is why we kept him on the amiodarone. So this is just a quick reminder of the CHADS-2 VASC score, which we now use routinely. And had we used it 10 years ago, he would have scored 2 because of his age and because he presented with congestive heart failure. So his annual risk of having a stroke in the absence of warfarin would have been in the region of 2 to 2.5%. It's quoted at 2.2%. But of course, every time we make a decision on anticoagulation, whether it's a novel oral anticoagulant or warfarin, we have to at least do a mental calculation of the patient's risk of bleeding, and we routinely use the HAS-BLED score.
So is the HAS-BLED score something that we use just to prognosticate or consider the risk of bleeding, or do we actually use it to modify the anticoagulation that we use? Would you, for instance, say if the HAS-BLED score is high, would you not use anticoagulation? Is that something that we do?
I think the scores are designed, particularly the HAS-BLED score is designed to tell us whether anticoagulation is safe or not. If a decision regarding anticoagulation based on the CHADS-2 VASC score has been made, but we cannot safely anticoagulate the patient, we would have to think of alternative treatments. We'd have to think of the left atrial appendage occlusion device in this case.
So if a patient has a definite indication for anticoagulation and has a high HAS-BLED score, would that perhaps move you to using something like a newer anticoagulant, like a DOAC, because we know that it has been shown to have lesser bleeding risks?
I think, as you all know, the data of NOACs versus warfarin is that they are very similar in terms of safety profile. However, NOACs are probably safer with regards to brain bleeds, whilst warfarin is the other way around. We probably would still want to anticoagulate the patient, particularly if the CHADS-2 VASC score is high. But I think in reality, we will have very close conversations with our gastroenterology colleagues with regards to the true risk of bleeding on anticoagulation. Of some relevance in this case, sometime later, he was diagnosed with CA bowel on bowel screening. There were no metastases, so he had successful surgery. And importantly, there was no bleeding, so therefore we did not stop the anticoagulation, which I'm sure is the right thing to do. 3 years later, in 2011, he represented with heart failure an ejection fraction of 23%, left bundle branch block at 130 milliseconds, and a dilated left ventricle measuring 6.5 centimeters and diastole. Of course, we restarted the warfarin, which we should have never stopped. Does anybody have any thoughts on what we should do next at this stage? So we had the initial presentation to hospital, heart failure, AF. He got better in sinus rhythm, stayed in sinus rhythm for 3 years. He represents, at this point, almost identical in atrial fibrillation with heart failure, with documented LV dysfunction.
I think the fact from what we saw that when he was in atrial fibrillation, the ejection fraction had gone down, and the fact that when he was converted to sinus rhythm, it improved, and now again he's coming with AF and with reduced ejection fraction. We would probably assume at this time that the LV dysfunction was due to the atrial fibrillation per se, and it would be a good idea to convert into sinus rhythm and try and maintain him sinus rhythm. The question is, what are the options we have? So.
We had all options available, but of course, we felt that the most likely diagnosis here was AF-related cardiomyopathy, with clear documentation of poor LV in atrial fibrillation and clear evidence of normalization of the heart function in sinus rhythm. So in the short term, we repeated the cardioversion, and we referred him to Oxford for an AF ablation. He was treated as early persistent and quoted an 80% success rate in the long term with a probably 40 to 50% chance of redo to achieve the 80% success. In any case, the AF ablation was successful. He remained on anticoagulation for life, and we agreed that this was AF-related cardiomyopathy. There are usually some factors which would influence which way one goes with regards to rhythm control versus rate control. No doubt you're all familiar with the AFFIRM trial, which was published in 2001. It had 4,000 patients in, and it essentially told us that rhythm management had no advantages over rate control in atrial fibrillation. But there are big caveats to the AFFIRM trial. One of them was that the anticoagulation was stopped after 4 days of sinus rhythm. And this is not something that will be replicated in real life in this day and age. There was also a subset of the AFFIRM trial which showed that if patients came back with recurrent atrial fibrillation after cardioversion, a rate control strategy was not inferior to a rhythm control strategy. In terms of what antiarrhythmics, there are lots of options available. We try and avoid class 1 agents in the presence of structural heart disease, coronary disease. We tend to use beta blockers, which are safer, generally speaking. However, this is an important slide because it shows that out of all the measures we take in treating the huge burden of atrial fibrillation, the ones that really matter are anticoagulation and preventing heart failure. Everything else is about symptom control. And I know that Cabana trial was presented recently, and it was not a positive trial when analyzed on an intention to treat basis. But it's worth mentioning that the only thing that will preserve life is anticoagulation and addressing the heart failure. Interestingly, after his successful ablation, he came back in 2014. And he came back in with that ECG. But the most important thing it told us was that this time it feels different. My heart is out of rhythm, but it feels different. So of course, we send him back to Oxford, although if you look very carefully at the ECG, there is some regularity to it, so it looks different from the original AF ECG. Although it looks fairly regular, it's unlikely to be a typical caval tricuspid isthmus-dependent atrial flutter because the flutter waves are not negative in inferior leads. So when he went back for the ablation, we actually found that the veins were completely isolated, but he had a perimitral flutter. And this was not the result of the ablation itself, so he had the perimitral flutter ablated, and at the same time he had the right atrial flutter ablated because they were there anyway. And everything went well. In 2016, he had a reasonable quality of life. His left ventricular function remained moderately impaired, so it never picked up. A cardiac MRI suggested that the pathology here was some sort of idiopathic dilated cardiomyopathy. We discussed CRT, but he didn't really fulfill the criteria. His QRS was not broad enough, and his ejection fraction was not poor enough. Unfortunately, he died later, but he died of an unrelated illness. He developed prostate cancer and died because of metastases. What I haven't told you was that before his initial admission to hospital, I'd seen him in outpatients. So I'd seen him in outpatients with this ECG. And when I saw him, he was short of breath, but still managing to play tennis. He told me that he'd probably had a viral illness before his shortness of breath. His ejection fraction at that point in time was remarkably low. He was 21%, the heart was dilated. Importantly, the left atrium was also dilated. So now, going back to the original presentation, he is in heart failure and he is in sinus rhythm. So the discussion point is, was this really AF cardiomyopathy? Or was the atrial fibrillation a manifestation of an earlier cardiomyopathic process? Do you have any thoughts, Rohan, or anybody else? Before I give you my thoughts.
I think one more question. In persistent AF, when you have achieved rhythm control, would you be doing simple tools like 24 extended monitors to make sure that these patients remain in sinus rhythm throughout, or whether to make sure that they don't get silent episodes of atrial fibrillation? Before, especially to take treatment decisions like discontinuation of warfarin or antiarrhythmic medications?
So if I understood the question correctly, do I keep an eye on these patients intermittently to see if they redevelop atrial fibrillation? No, not routinely. It's based on clinical presentation. If patients come back and they have recurrent palpitations, we will of course investigate for atrial fibrillation. If they remain well, as this gentleman appeared to be for several years, then we did not do further Holters to see if he had paroxysmal atrial fibrillation. Maybe we should have done. Maybe we would have picked up further paroxysmal atrial fibrillation. But the important thing to say is my original instinct, when I first saw him, I had doubts that we would be able to maintain sinus rhythm in the long term. My thoughts 10 years ago were that we probably were going to think about cardiac resynchronization. My initial thought was that this is not AF-related cardiomyopathy. However, when we saw normalization of the LV function in sinus rhythm, I think we will be probably forgiven for assuming that this is an AF cardiomyopathy. But I'm happy to take any open criticism from anybody. You're thinking sarcoid, Rob. No, We didn't do that, but relatively early on in the process, we did do a cardiac MRI, and there was no suggestion that this could be sarcoid. Completely agree, maybe we should have done an ACE level.
It's a very interesting case.
Thank
I have
you.
to congratulate you. I think that your gut instinct right at the beginning was correct, and that he had a cardiomyopathy, and that when he went into atrial fibrillation with a fast rate, the myocardium couldn't cope. And that's why he ended up in failure. And then by getting him back into sinus rhythm, it kind of was a temporizing measure. It's just we don't really know what the cardiomyopathy process was. Sarcoid would fit mainly because of the differential fibrosis, and he keeps getting, despite an ablation. I thought he may have had a roofline atrial tachy after his ablation. That's what I thought that ECG was, but actually you said it was a mitral focus, so it was a de novo lesion. So it'd been very interesting to do an autopsy of the heart when he died, I guess.
Yeah. I completely agree. Thank you for the comments. His initial AF ablation was veins only. He did not have any roof lines. The second time, the veins were isolated. The perimitral flutter was probably coincidental. I completely agree also with your thoughts on cardiac MRI. Remember, the cardiac MRI was performed a few years down the line. And the exact reason we did it was to look for sarcoid. It didn't pick up anything to suggest sarcoid, and we hadn't repeated it a year or two later, but the presentation with both AF and flutter would fit in. So this was unlikely to have been a simple AF-related cardiomyopathy.
Okay, this is the end of the session. Thank you for the informative discussion. May I call upon Sir to accept the token of appreciation on behalf of Heart Association.
Ladies and gentlemen, we have come to the end of the lecture series, but the night is still young, so we kindly request all of you to please remain seated. The most interesting parts are yet to come. Before that, I would like to invite Dr. Bhatia Ranasinghe to deliver the closing remarks.
Thank you very much. I'm not going to waste your time anyway. On behalf of Sri Lanka Heart Association and the Council, and also on behalf of Academic Committee, I would like to conclude the academic session, and we had 2 busy days. Previously, meetings we used to have 2.5 days and 3 days academic session, and actually we shortened it to 2 days. Apologies to have a compact program, but at least it is very well spaced, and we have covered most of the topics. And this time we had faculty members, both local and overseas faculty. And overseas faculty came from different countries, the America States, and then the United Kingdom, and Portugal, United Arab Emirates, India, and Australia. And thank you very much for coming all the way. I suppose you have enjoyed the program, and thank you for giving us the excellent knowledge for us, and it will help the patient management. And various topics are covered, including the preventive cardiology, interventional cardiology, and also the surgical aspects, and also the guidelines, the case-based discussions, various quiz. So all aspects being covered. And hope you all learned and updated your knowledge in cardiology. And I wish you all a very happy journey back home, especially the international faculty that come from various countries. And thank you very much. And I'd like to conclude the academic program and hope to see you all next year. Thank you very much.